So this is Pediatric Emergencies Part 2. So when a child comes to the emergency department, the standard laboratory and diagnostic tests that we're going to obtain are electrolytes, glucose levels, CBC, right, that H&H is going to tell us if they're losing blood, basic metabolic panel, and I would say that along with a couple down, the ABG, that's going to tell us if we've got a metabolic or a respiratory problem going on. Blood cultures, because remember, septic shock is a real possibility, so we need to know what germ is causing this. Urinalysis. The perfusion of the kidneys is going to make the urine either concentrated or not concentrated. So the urinalysis tells us a lot about cardiac output. ABGs, I already said. Toxicology panel, especially if we think this child might have ingested something. And then an electrocardiogram and chest x-ray. So differences but that the American Heart Association recommends between adult and pediatric chain of command or chain of survival. Remember, with adults, we want an early activation of the EMS, then do CPR until somebody gets there with a defibrillator. In adults, we're really trying to get early defibrillation because those defibrillatable arrhythmias are the ones with the best outcomes. If we can do early defibrillation, and then we get them to advanced care. Pediatrics, we're not worried about ventricular fibrillation. We're worried about a respiratory arrest. So the first thing is let's prevent it. Let's not have small things around for them to aspirate. Let's not have pools that aren't fenced. So prevention first. And then if something does happen, early CPR so that we get some oxygen in them. We get that oxygenated blood circulating, and then we call the EMS and get them to advanced care. And if you remember, on CPR, they've changed it to its 30 compressions to 2 breaths, regardless of infant child or adult, if you're by yourself. If then another person comes who's trained on infant and child, we're going to switch to 15 compressions to 2 breaths. And how you do infant, you can do either 2 thumbs or a couple fingers, and with a child, palm of one hand is the recommended right there on the sternum. Okay, if we do have to do chest compressions, we want to make sure the rate and the depth is adequate. So the rate needs to be a minimum of 100 per minute and deep, but allowing the chest to fully recoil. So let the chest come back to normal between. We want minimal interruption of chest compressions. So they should keep going, and when somebody's tired and needs to change, that can be when you stop to check if they're having a pulse on their own and then change places, but to try and keep those few and short, the interruptions. When we do 2-person CPR, you can do your thumbs again either way, and with that 2-person CPR, it's 15 to 2, but the person doing compressions is not going to stop or coordinate the compressions around the breaths. You just go ahead and keep compressing, and the person gives the breaths. So PALS uses this mnemonic DOPE for troubleshooting an intubated child. If we have an ET tube in and we're having trouble with it, is first look, is the tube displaced? Has it slid out so it's no longer where it should be in the trachea? Is there an obstruction, a mucus plug in the tube? Is there a pneumothorax? And this kids usually take a really fast and sudden turn for the worse respiratory wise. If we've got that ET tube in and we're ventilating them, there's always the risk that we're going to use a little bit too much pressure, pop a lung, get a pneumothorax. And then the E is equipment failure. Has something come disconnected or have a leak or power loss going on? So things you're going to see if this emergency situation is because of a toxic ingestion. And this happens, unfortunately, fairly often. Kids see grandma's medicine and think it's candy, and they take it. So you can get hyper or hypotension, depending on the medication, hyper or hypothermia, again, depending on the medication and what metabolic changes it causes, respiratory depression or hyperventilation, and then miosis, which is pinpoint capillaries, or mydriasis, which is dilated, I say capillaries, pupils. So pinpoint or dilated pupils. And sometimes students will do their assessment and say, the child has, whatever pupils, and I'll usually say, so what seizure medicine did you just give? There are medications that cause that. It's not necessarily, a head trauma sign.